I am going to start out. I'm privileged today to speak to you about aging and sexuality. Let's make sure the slides. Okay. Just to let you know, I don't have any financial disclosures or any conflict of interest today. Just to give a quick overview, I'm hoping to lead you through just a quick synopsis of aging and sexual research. I think it's important to know where we're getting our information and how this can apply to our patient population. We'll look a little bit at sexual activity and behaviors, look at some of the STD, STI data, look at barriers to care, and then I'll introduce a screening tool that I think may be helpful in terms of reducing some of these barriers, and then talking a little bit about sexuality and cognition today. So the research, there are different major research studies, longitudinal studies that we're able to pull social demographic from so that we can understand our aging population and understand sexuality within them. Today, I want to highlight one specific study, which is the National Social Life, Health, and Aging Project. So that project is a representative population for us here in the US. It's a longitudinal and population-based study, and it looks at home dwelling adults, typically those ranging from being born in 1920 to 1947. And so from this cohort, there have been different waves of the data. So the first wave of collection happened in 2005, 2006, with interviews in approximately over 3,000 participants. And then second wave occurred in 2011, and this time it incorporated the spouses or partners of the participants of the first wave. So keeping that in mind as we go through and we talk a little bit more today on these topics. So one of the landmark studies in this topic is from Dr. Stacy Lindau and others on sexuality and health among older adults. It gives us a framework in terms of understanding sexuality in our older or aging population. Some of the major findings that we get from this study is that we get to acknowledge or see that sexual activity declines with age, and uniformly sexual activity is lower among women than men. We see that there is a likelihood of being more sexually active depending on health status. So if you feel as though your health is great or excellent, there's a greater likelihood that you'll be sexually active. What we also see is that at any age, women are less likely than men to be partnered, whether marital or to be in a relationship. And we see that increase become more significant as we age or as they age. And then among men and women, men are more likely to be partnered. And one of the things I'll talk today about is with the barrier in terms of communication. The study highlights that we don't talk enough or address sexual health with our population enough. And within the study, it showed that 38% of men and only 22% of women had any discussions with their physician about sexual health after the age of 50. So this is just a graphic depiction. I want you to focus on box A here, and I'll walk you through it. So on the y-axis is the percentage of participants that were sexually active within the past year. And on the x-axis here, it does the grouping in terms of age. The key here, the plus sign represents participants who rated their health as excellent. The triangle are participants who rated their health as good, and then the circle are participants who rated their health as fair or poor. And then blue represents men and red represents women. So if we just look at the trend across, we can see what was stated before that with age, there is a decrease in sexual activity, both with men and women. We can see that women tend to be less sexually active than men in comparison. But what is key to note is looking at the trend with the plus signs going across. So the plus signs, again, representing excellent or very good health, those are the highest, that group represents the highest sexual activity across age. So we want to keep in mind, B and C are similar trends, but specifying whether participants are partnered or in a relationship. And we want to keep in mind then that sexual health and partnership plays a big role in terms of sexual activity in our older population. And that segues into what we're seeing in terms of data that's represented with sexually transmitted infections and sexually transmitted diseases. This represents a time frame between 2012 to 2016. The first cluster of graph bars here represent chlamydia, gonorrhea, and then the third, syphilis. But across, we can see that trend that over time it continues to increase. The most updated information that we have, there's an overlap in terms of the time frame from 2015, but up to 2019. We see that the trend continues. So the blue represents chlamydia, and we can see it seems that the biggest transition has been between 2018 to 2019. There seems to be the bigger jump here. Not sure what created that difference there. And then orange being gonorrhea, and the same trend that we're seeing with syphilis. So this is almost over a 10-year span, and we have not been able to see a drop or improvement, and we continue to see a steady increase. So acknowledging and recognizing the importance of sexual health, sexual activity in our aging population is impacting their health. So why are we not talking about sex? What are the barriers to us addressing this within our population? The barriers start with us as clinicians and also with our patients. As clinicians, we do not get a lot of training in terms of talking about this topic. It can feel uncomfortable both for our patients and for us, as sometimes we may mirror either our patients' children or their grandchildren, and vice versa. Who should initiate this topic? When is the best time to bring it up? Is this something that you should talk about at an initial encounter? Is it something that is best done at an annual wellness visit? Is this something that's better done in between visits? When is the best time to bring this up? And then it's also shadowed by the negative societal attitudes in terms of our aging population and sexuality. There are stigmas, there are taboos in terms of what should be done or should not be done in this population. And a lot of time our patients are bringing family members, caretakers with them to their visits. And so that creates another level of barrier for them to have that discussion. So it's very important that we are helping to break the barrier by being comfortable with this topic, by initiating this topic on our own. And in terms of the best timing for us to initiate this discussion, we want to make sure that we have a rapport with our patients so that we can bring this up. When we're introducing new medications, that's an opportunity as we're going over side effects to be able to talk about this. If we introduce something like an SSRI, we can use that as a bridge to that communication. We can also use it as health changes, as function changes. And if we're talking about function with our patients, we can use that as a bridge to say, what about sexual function? How are things there? So a model that I want to introduce to help us in terms of communicating and feeling comfortable bringing up the topic is what's called a PLISSIT model. And this is a model that was an open-ended question. This model was taken from sex therapy and redesigned to help practitioners be able to address sexual health with their population. So the first question is very open-ended, and it starts with, can you tell me how you express your sexuality? From there, we're asking, are there any questions or concerns about fulfilling your sexual health that we can help with? In what way has your relationship changed? And what information can we provide? But even if we just start with that first question, can you tell me how you express your sexuality? That can open up a lot for the discussion, if not at that time, but at a later time, and your patient knows that you're invested in them and their sexual health and that you care, and it opens up that window of communication. So we've been in the pandemic for approximately two years. And if you turn on the TV, I feel like at least once a week, if not twice a week, there's some discussion in terms of cognition, more the diagnosis of dementia or mild cognitive impairment. That seems to be getting more news time and awareness. And it would appear from the statistics that there is increasing numbers in terms of Americans living with Alzheimer's dementia. The Alzheimer's organization has it as approximately 6.2 million Americans age 65 and above are living with this diagnosis. And when we look globally, the World Health Organization has data that supports that up to 55 million people are living with dementia, not a specific type, but just dementia worldwide. So it's something that is at the forefront, or seems to be at the forefront in discussion. And so I think it was important, or I think it is important to highlight this new study that was done in 2018 that correlates sexuality and cognitive status, helping us to get some sense of how cognition is impacting sexuality within our population. And so again, another effect of the pandemic has been that more of our seniors are in their homes. So families during the surge in the pandemic went and took families out of assisted living circumstances, brought them back into the home. So we have more of a home dwelling population. And this study takes the data from that second wave that I introduced before, and that becomes a little more representative of our patient population that we're seeing now as a home dwelling population. So I think that this kind of helps to open up and give us some insight on things to think about as we're seeing more changes in cognition and we're having more home dwelling seniors. So the objective of this study was to look at the prevalence of sexual behavior, problems, attitudes in individuals with different cognitive status. And just to lay the background in terms of how cognition was defined, they used the MoCA assessment, and anyone that scored over 22 was defined as normal cognition. Anyone scoring between 18 to 22, MCI, and then less than 18 was defined as dementia. So what we saw from this data that was pulled is that among sexually active participants in this study, the frequency of sexual activity was similar across cognitive groups. So whether someone was diagnosed with dementia or MCI or normal cognition within this group, we saw that sexual activities stayed pretty similar. 3/4 of sexually active people engage in vaginal intercourse. Putting that back into perspective as we're talking about opportunities to intervene for counseling regarding STIs, and looking at our population in terms of what we need to be doing to help to curb those that trend. Again, rates of oral sex was similar among men and women, but decreased with cognition. Across cognitive groups, the majority of men and women express positive attitudes about sex. So this is something that we need to be cognizant of and bear witness to for our patients, so that we can also help them as they're going through these changes to support their needs. Approximately three quarters of men and women across cognitive group report at least one sexual dysfunction. And from looking at the dementia population, only 1% of women and 17% of men spoke to their physician or clinician about sex life changes. So this graph, just a quick orientation, let's just focus on C here. This is looking at participants who are sexually active within the past year. We're looking at the different age groups on the x-axis, and plus sign represents dementia patients, the triangle represents MCI, and the circle represents normal. And so we see, as we did before in the prior studies, that across age group, sexual activity decreases. Men are more sexually active than women. But what we're seeing here is how clustered the different groups are between dementia, MCI, normal cognition, how clustered. There isn't a big gap or difference. And so showing, again, just a visual representation that sexual activity stays similar across cognition. So we know that as we age, there are particular physiological changes. For men, testosterone changes with reduction can impact their sexual desire, arousal, impact erectile dysfunction, premature ejaculation, and also causes an increase in refractory between erections. And so that becomes an opportunity for us to make interventions. And I'll talk about that in a bit. For women, noting the decrease in estrogen level causes changes in vaginal lubrication, thinning of the mucosal membrane, vasocongestion. There's change in size of breasts, uterine size, and vaginal size changes, and also erogenous zones, the sensitivity, nipples, clitoris, etc. Those change as well. And so a decrease, when I say change, those decrease. And so it gives us the opportunity, as I said, in terms of medications, to be able to assist patients with their sexual health. Looking at it from a medical standpoint, is there any external factor that we need to be addressing and screening for? Diabetes, hyperlipidemia, some examples. We're looking at supplements. You'll always see that this is a target population for commercials to start supplements, anti-aging supplements that will make you feel great. So being mindful of screening for supplements as well. And then for women, the discussion regarding hormone replacement therapy, estrogen, androgen, topical therapy, vaginal estrogen cream, doing pelvic floor exercises to help in terms of intercourse and comfort. And as we saw there, that the highest percentage of sexual activity was intercourse amongst the population screened. Some additional interventions that we can express and talk with our patients about is giving them information about allowing for greater time for foreplay, using water-based lubricants, being mindful to screen for depression, and also, again, coming back to that counseling opportunity that we have for STIs and safe sex practices. So that was a quick synopsis. I wanted to be mindful of the time and give some opportunity that if anyone wanted to ask any questions or give opportunity for me to elaborate on any areas.
Thank you so much, Dr. Rodney. If anyone has questions, feel